So this has been a great day, an amazing amount of information. You know, it would seem like if we all just stayed in the room for another few days, we could solve all the problems here with all the brain power we have. But we're going to all go off and solve it independently. I have to admit, first of all, that I was given the title was Novel Paradigms for Chronic Disease Management, which is like talking about, the title is healthcare. So really what I want to focus on is, the subtitle is Measuring Meaningful Change. And really there's sort of three kind of related concepts that I want to summarize that I hope to sort of cover. First of all, what I think is new, and we've heard a lot about today, is there's this paradigm shift in measuring, hopefully, meaningful change. And this is critically important because, and I'm paraphrasing Maxwell, the famous physicist, if you can't measure it, you can't change it. And there's a lot of, I think, truth and power to that. And I think what's also really interesting about this concept is that the assessment is really moving more and more into the home, the community, the person. So I'm obviously going to expand on this in hopefully a little bit of detail. But I want to start out first by something that's been already mentioned to some degree, a few times already. There's something that happens over 2 million times a day. It takes on average 15 to 16 minutes. And in those events, there's about, on average, 6 topics discussed. And as we all know, that's the doctor's office visit, the clinic visit. And this ritual hasn't really changed very much. You know, the wallpaper's changed, and there's Wi-Fi available, and there's there might be an EMR available. But the actual visit has not really changed very much at all over many, many decades. What goes on in that office? So if you sort of think about the anatomy of an office visit, this is a figure that I took from a favorite paper of mine from a few years ago that was the result of audio recording a number of clinic visits around, I think this was in 4 different practices around the country. And then these were hand transcribes. This was low technology. Graduate students did this work. And then they were annotated in terms of who was doing the talking during these interviews. And then the actual topics were then categorized in each visit. And what you see along the bottom axis is just the time, that 15 or 16-minute time interval. And then along the vertical axis are the topics that were discussed. And basically you see the doctor spoke first briefly, and then the patient probably said something about their hip, and then moved on to depression, and the doctor came back and forth and back and forth. And what they finally end up with is a little comment about their gums. And then it was goodbye. And what I think is actually, when you think about what's remarkable here, is it's amazing that anybody ever gets better. Or perhaps people often will get better on their own, which we always need to keep in perspective. But what I think is really important, and has been brought out many times today, is all of this is very artificial, and it occurs in this very special brief period of time, and it ignores the rest of life. Another way to look at this from a data-driven point of view is what we are typically doing to detect meaningful change is, if you think about those that are lucky enough to see a doctor on a continuous basis, or I guess if you had a record that was reliable, you might record a number of events over time, and these could be blood pressure measurements, cognitive function, walking ability. And you would look at these data and you'd say, okay, well, it looks like if the scale goes this way, they're getting worse. But then in the real world, people will report some kind of symptom. And then you sit there and you have to scratch your head and say, well, how does that relate to all this other data? Well, imagine if instead of this current system, you had data that really reflected everything that was happening, or at least was continuous and recorded every day. You'd find that, in fact, there wasn't a real change in the absolute values, but really what you captured was mostly bad days, which is typical when you have a visit to a doctor. You don't usually visit doctors because of good days. But if you look closely, the real difference is in the variability over time. And that's something you could never detect unless you had very frequent data. And ultimately, if we're lucky, that early change may be a signal of early detection. So this is a theory. There's a lot of work that goes behind believing that this is true. But the real question is, can we actually get data that suggests that this is true, and how can we use this for meaningful outcomes? To get to this point, we are going to have to change this assessment paradigm. We're going to have to change this brief, episodic, clinic-based, obtrusive, inconvenient, unpleasant often, not engaging, not fun assessment, and go to a more real-time, continuous, ideally home-based, and minimally or unobtrusive assessment. How might we get there? Well, I think a lot of the discussion today has sort of presaged what I'm going to say, and that is there's a lot of potential power, ultimately, in collecting information that's actually available out in the community. What I'm showing here is the layout of a home, typical home, a small home or apartment. And we all know that there are a number of sensors or devices that can give us information, ideally passively, or ambiently. I like this term, ambient sensing. So what we can do, or what we do, is we can take passive IR sensors, strategically place them about the home. There's a gross measure of activity. That's where the purple triangles are, pink triangles. These same sensors can be repurposed and field restricted to provide walking speed. And I'll show some examples of most of these shortly. Door sensors can be strategically placed on important doors, like exit doors or refrigerator doors. There's a lot of things that can be done that are needed to be done with self-report, and this can be done with computers, with phones, with purpose-built kiosks to get experience-sampled results that are needed to do things like formal cognitive testing, measure social engagement, or coaching, which is something we heard about just a while ago. There are a number of important medical things that can be looked at. So medication can be tracked electronically. I'll talk about that in a moment. Lots of important activity happens when we don't have any clue about it. That's what happens at night. Can anybody remember what they were doing 5 nights ago? If you can, it was probably really good. But it is really hard to know, and there's no data about this. Does anybody really know how much, exactly how many times the average 65-year-old goes to the bathroom at night? It's very hard to quantify. It's all self-report. Is that speaking from experience, or? Phones can be censored, and there are lots of things that one can obtain from phone sensing, like social activity. And then there's old-fashioned telemedicine. This tends to be the thing that we all kind of focus on, measuring glucose and blood pressure and weight and so forth. And there's nothing wrong with that, but it's become a very dominant concept here, and in many ways I think has limited our ability to think beyond just this kind of single reflex arc of measuring a physiologic function and then reacting to it remotely. Now, all of these things can be done quite ambiently, quite unobtrusively, but there are some things that we're not that great at, and those are these kind of body-worn kinds of sensors, things that people have to wear. They have the disadvantage of often needing to be charged. They don't work very well in the shower, or you need waterproof. Phones are terrific, except it's not clear that people really carry their phones with them all the time at home, or if they are, then they're not being charged. So, so there are some challenges there. But this is a basic kind of platform of elements, but by itself it's just the technology. So these are all the hammers that people are using. Different companies say, well, it's got to be on a, we're doing bed sensing, or we're doing, mobile phones, or this or that. It's really, I think, important to consider this ecosystem, if you will, as the place to get the information, or the methodology to get the information. The real key is to take these elements and apply them to answer specific and important questions or get meaningful data. So here I've just arrayed what is a typical platform in the research that we do that might be put in a home. Now, individually, this would be called a smart home. Many of these exist at university centers and biomedical engineering departments.
The data that one gets out of them applies to a typical graduate student who's generally existing on a diet of Coke Zero. And so it doesn't really reflect the real world. And what we really want to do is scale this out into the community. And larger communities, we've heard a lot about scale. Scale is important, and we need to do that. Of course, the power of the internet is really what makes this all possible. And then, of course, the data comes back for analysis. Now, we could end here. There's lots of these diagrams that float around. But I think what's really important is to go back out and think about what's the efficacy? What's the evidence that these approaches might work? And it really begins with thinking more about the people, the users. It's not about the technology. It's about the people who might use the technology. And it's not just the patients or the older population, but it's also about their adult children. It's about the health providers, of course, and other interested parties. So we spent a lot of time focusing on understanding what people think about technology, about these solutions, before one actually then goes into actually looking at the technology and how it might work in a smart lab or apartment. Once that is understood, I mean, after all, you want to know how the technology works, how reliable it is, and so forth. But once that's done, what we found very important is to take this out into the community, into what is typically now maybe called a pilot study. We have in Portland what we call a living lab of a standing number of adults who agree to have this a basic platform in their home, and then we can put things into their home or ask them to do certain health practices to get an idea how these things work in the real world. So with that in mind, I'm now going to, because of the time constraints, I'm going to give a tour of the evidence, if you will, of how these kinds of systems might work, what we're learning, and why this is important and relates to the future build-out and development, whether it's in business or in nonprofit sectors. And I'm going to start with the example of something called everyday cognition. And this is really what we're all doing right now. Some of you, well, many of you are looking at your smartphones, but that's part of everyday cognition. In fact, the important part of everyday cognition for most of us is multitasking. But one of the other important parts is what you're thinking about now, and that's prospective memory. So you're all sitting here because this is the last talk of the day, and you're thinking like, well, I'm gonna get in my car. Is there gonna be traffic? I got to pick up my shirts at the cleaners. Oh, I got my daughter's at soccer practice. That's prospective memory. Can we look at that and measure this meaningfully in a healthcare application? And the most important prospective memory task is remembering to take your medications. And this is done most widely by using the familiar plastic pill box. How do we measure prospective memory in the clinic? We ask people to remember a list of unrelated words. How many people do that every day? Okay, so he's probably in a dementia clinic. That's a HIPAA violation, I think, somewhere. He probably thinks it's going to protect him from getting dementia. Anyway, one way that we've approached trying to get at this unobtrusively is to take the familiar pill box. So this is going back to starting with the individuals, what they feel comfortable with, and just simply instrumenting it so there's a switch on the door, and when the door is open, it tells us the time of day. This is a figure from the original prototype, which in classic fashion was literally built in a garage. But what does this tell us in terms of function? Well, in one of our earlier studies, this was done by my colleague Tamar Hayes, we looked at how a group of older octogenarians, primarily women, primarily living alone, might be able to take their medications and see if we could detect how the influence of maybe even mild cognitive decline might play a role. So we asked them to take a vitamin twice a day. Now, this is not a normal, most people don't take vitamins twice a day unless they forgot they took it early in the morning. But we wanted everybody to have the same challenge to make it a fair playing field. And we tested them in the beginning of this study all with a standard cognitive test, and basically just divided them by a median split into those that are in the higher end of the stick and the lower end of the stick, which is just that's the way it is, and I'm not implying that any side of this room is higher or lower, although somebody has got to be below us in any group. Which reminds me of, there's an old Woody Allen joke, which is this is related to healthcare. Imagine this, somewhere in America, somebody's sitting in the waiting room in the doctor's office of the worst doctor in America. It has to be, it's just statistically, it has to be. Okay, so what are the results of this study? What was noted was the group that was luckily in the higher side of cognitive function were very good. They were actually 80 to 90% accurate in adhering to this medication regimen. On the other hand, those on about the lower end of the stick, so to speak, were significantly worse. They were actually in the 60% range, which actually in a clinical trial would have kicked them out. You need to be at least 80% adherent to be considered to take the medication adequately to prove efficacy. The implications of this are huge. 50% of all people taking medications supposedly don't take them as they're prescribed. It may be because they have actually medical conditions that make them just a little less clear in the head, and this is well known. So, but we merely go about prescribing medications and thinking, oh well, we know what's going on, and if a person's blood pressure is high, we just add we add another medication. Knowing actually what's going on over time can be incredibly powerful. So this is just one example of an individual using this kind of device over 3.5 years. And you'll notice there's two dips in their adherence pattern. The blue line is their just total adherence over this time period. And what do you think those represent? That's right. Happy New Year. This is the effect of holidays. And you can imagine if you went to the doctor's office during the holidays, you might find that the person was doing worse simply because they were busy or they had something they ate during the holidays interfered with their medications. And actually that's part of the point, is to relate all this data. Another important example is physical activity. We talk about this, it's extremely important. We measure it imperfectly in terms of self-report. We measure it directly in the clinic by asking people to walk in terms of their mobility capabilities. We measure it with a stopwatch if it's measured quantitatively. So this is the perfect instrument that's used. Here I show you some data of this walking speed measured with a stopwatch in an individual over a couple-year period. You say, oh, they're getting better. Well, if we take the sensor lines, so the sensors that I talked about before, you put them in series in the ceiling of a house, and the picture shows what the sensors see. There's no cameras, this is the field of view. What you then begin to realize is real walking in the community or in the home is a population of walks with incredible variability. When you have that data, you can begin to model the trends and change over time. You can look at fast walking and slow walking, populations of fast walks. You can relate them to where they came from. So most fast walks come from going to the bathroom or to answer the door or the telephone. Now, there's so many aspects of this that I could talk a long time about walking, but just to give you a flavor for the richness of this data, there's almost a challenge to present the data. There is a challenge. This just shows, if you look on a group basis, that walking speed actually varies throughout the day. It may depend on when you show up in the clinic by itself. Now, by itself, this is interesting, but can we take these data about walking and relate it to actual health outcomes? One of our early studies, again, directed by my colleague Tamar Hayes, we looked at this walking variability. Because remember in my original model, variability might actually be the first thing to go. And what we found, of course, perfectly, because we're geniuses, that variability does really seem to differ in people with, in this case, very mild cognitive impairment. And it actually didn't matter over what time periods we looked at. We've extended this now to look out over, in this case, it's 182 weeks. We found that there are actually populations or trajectories that typically characterize older people. And consistently, those with mild cognitive impairment are 10 times more likely to be in this slow group. And so this is a very promising way to unobtrusively detect when people are declining. There's also something very interesting that I learned serendipitously. By just having these systems in place, you can discover things that you never anticipated. So what I'm showing here is these are spiral plots of two individuals that lived in a retirement community where there was a norovirus. Norovirus is a GI virus. It causes diarrhea and nausea. My son just got it. And he's only 4 years old. He doesn't live in a retirement community. I don't know that the environment in our house is not unlike a retirement community for him. His meals are provided, there's socialization activities, etc. It's very nice. And he's into the quantified self, so he's trying to figure out how many peas he can put up his nose, and he's very good at counting this. He's 4 years old. In any event, the spiral plots are a way of showing activity on a 24-hour clock. So at the top of the clock is midnight, the bottom, 1200 hours, is noon. In this case, the concentric blue circles going outward are 2-week periods, and the colors show where the activity occurred. And so what you can see in these two patterns is that people during the nighttime hours are in their bedrooms. There's a lot of red dots, which means they're in the bathroom a lot. When I show this to graduate students who are under 30, they're like blown away. They can't imagine they go to the bathroom at night. But what's interesting also about this was that in this case, so you talk about behavior and group behavior, the individuals in this community were asked to not congregate during the viral epidemic, and that's this 2-week period shown here. And these individuals were very compliant, so this is the 2 weeks before, 2 weeks after. And so in each case of these two people, they stayed in their home more. So you can see there's just more activity in the home. And also, they didn't go down to the communal dining area, so they slept in. So there was maybe a silver lining to this for them. Now, for those of us who are into the quantified self, like my son, this is of great interest. But what we also wondered was, could we then take this kind of data and predict, without knowing, who might have come down with the virus during this 2-week period? And we figured that just simply, actually there was an interesting discussion among all the algorithm developer doyens in our group of all these complicated support vector machine algorithms and things. It turned out that just room transitions were actually very powerful in predicting, and there were only 17 people in this community that were monitored, but we were able to pick out precisely the 3 people that came down with the virus and had much reduced room transitions, except to the bathroom. Now, all of that I've shown is passively obtained. The individual does not have to sign on, report in any way. But there are some things, as has been talked about today, that you can't obtain just passively, and important information. So there is this need to ask. And then the issue, I think, really is a very important one, is how do you ask? What are the best ways to get this information? And I think the answer is use whatever is most comfortable. Now, for some people, it might be a PC, it might be a laptop, it might be a tablet, it might be a TV, it might be an electronic picture frame, it might be a cell phone or smartphone, or many other ways. But the important point here is it's not about the devices, it's about trying to figure out what are the best devices, or how can we determine who might report most comfortably by different means. And then really, how frequently can you reasonably ask somebody this information? And we've sort of hit upon, at least in this octogenarian community-based cohort in Portland, Oregon, where everybody's above average, of course, that probably weekly, once a week, if it takes less than 7 minutes, is about the sweet spot, at least, again, in this special group. This is some data where one of the questions that we have been asking for many years now is, during the last week, have you felt downhearted or blue for more than 3 days? And what this shows is the weather in Oregon. so people do have seasonal mood changes. This, by the way, this is not, these are not people with major depression. These are actual, very subtle mood changes. Importantly, also, we ask them other questions, and we find that during the week when people go to a doctor's office, have a PR visit, change their medications, have visitors to their home, they report low mood, as opposed to the weeks where those things don't happen. Now, some people have really very limited capability, particularly among this older population, to use computers. So we've also developed some devices to facilitate their self-report. And we don't have a name for this, other than we call it a kiosk. It's a flat panel monitor. It's touchscreen sensitive. We've glued on the side a phone set that goes into the audio jack. We've taken away the computing unit. There's no keyboard or mouse. And then also have enhanced the chance for responding by using a sort of an intelligent video. So this is Jessica, who lives in Denver now. And she is able to help people answer questions, and also, for example, if there's a pause, she'll say, are there any more responses, or something like that. One of the nice things about this kind of digital data is we can also look at the number of times people ask to repeat the instructions, raise the volume, and it gives us some inklings on their cognitive function at the time. This device has now been deployed in a multi-center 26-city study. It's ongoing. It'll be done in July after 4 years, a long time. And so this data has not been vetted, but just to show that using, remember I talked about that 10-word list, or a word list recall. So using this device, we ask people every 4 weeks to do some of these kinds of tests on this device, and Jessica moves them through with this test. And then using automated speech recognition, you can actually score the test in an automated fashion. The point that I'm making here is that the traditional annual assessments don't show any change in slope. Whereas if you look at the monthly variability, again, I mean that is a variability measure, there actually seems to be a lot of important action. This study's been supported by the Alzheimer's Disease Cooperative Study Group, funded by the NIA, so I want to acknowledge that. Now, interestingly, that's all about formal testing, and I have to admit that that's the legacy of pharma, and we're going to develop a drug, and we have to get approval, so we have to have these tests that have been shown to work, or at least to be responsive to the drug. But what we also noticed is that if you just measure usage of the computer itself, just simple time on the computer, this seems to be a very sensitive measure of people cognitively declining over time. And that's what I'm showing here over a 32 months of continuous computer use in this population. There was a significant drop-off in those who had developed mild cognitive impairment over time. And so you can imagine if baby boomers, who are, figures keep changing, but maybe 80%, even up to 80% are online, the next generation of older folks, one might be able to screen large populations for cognitive decline with a very simple time-based measure. So I think the future is hopefully bright for using these kinds of pervasive computing in the home environment methodologies geared toward how people can function and work with these kinds of approaches, and use that to improve our outcomes. I think one of the real challenges is going to be that we continue to talk about is scaling. And so we've gone from, I think, a world where we've had some very nice demonstration projects or feasibility studies of technologies. I think a lot of times those have been rushed into markets or productization, and that's been a challenge because there's not so much evidence that things work. This whole issue of, it came up many times today, who's going to pay for it? Well, at a minimum, a lot of people are reluctant to pay for things that they have very little knowledge about how they might actually work or how efficacious they are. So to try to build this model out, there's two things that we're working on quite a bit. One is I've been very fortunate to be able to partner with Paul Crawford, who actually works for Intel in a unique public-private partnership called the Senior Independent Living Research Network, or the acronym is SILVER Network, or SNI. And the goal of this group is to build out a collaborative research environment to create a scalable national research infrastructure. 10,000 homes, 20,000 homes, it's a lot, a much larger scale. And the idea is actually to really create this as a pre-competitive space so that companies, academics can use this infrastructure to much more rapidly develop and test what we're all talking about. This has been one of the biggest roadblocks. Also, I have to say that we haven't been able to capture the imagination of our population in the same way that we have in other sectors that have equally little evidence but seem to be going gangbusters in terms of effort. So how many people think stem cells are going to cure all our ills? Here I am in California where there was a huge faith in that several years ago already. Well, oh come on, somebody must be just too embarrassed. Thank you. I hope so. Genentech, yes. Well, this is like, it's not a competition for what technology is the best. It's sort of like when you're raising money for diseases. It's like, well, cancer is more important than Alzheimer's disease, isn't it? No, they're all important. But I think that that the use of pervasive computing in healthcare and collecting this kind of data on a large scale, we haven't figured a message to capture the imagination of the population in the same way that genomics or stem cells or other sexier, for whatever reason, technologies have. And I think that's actually an important element that nobody's really talked about today. There actually is this thing about messaging, and here I am, an academic who knows nothing about messaging, the way I'm dressed. But it really is an important piece of this. There's something about motivation and energy that's a little bit more intangible, a little fuzzier, but in fact, it's a reality of what we all do. So the Silver Network is something that I think you're hopefully going to hear more about as time goes on. The Robert Wood Johnson Foundation just gave us some funding to move this forward. The Foundation for NIH is a partner in this, and hopefully will be helping raise some funds. Stay tuned. In the meantime, being a realist, we think we've done a lot of work up in the Northwest in this area for now over, it's about 9 years now. And so we're going to continue to try to build this model out. We've been in 1,000 homes collectively, although we haven't maintained 1,000 homes simultaneously. One of the exciting developments in Portland is this tower called the Mirabella. So it was planned in 2007. It's actually built and people are moving in. The developers put $500,000 of fiber optic cable dedicated for research. So this is kind of like a vertical living laboratory of several hundred people that we were hoping to move forward. There's a marvelous project, speaking about health disparities, Senior Sinai Park, which is a nonprofit health organization in Portland, is working with us and the state, and I think there's some CMS innovation project they're working on as well, or application, to marry technology with Section 8 housing residents and using these same kinds of models and figure out how this would work in a different group. So with that in mind, I just want to point out or thank a lot of collaborators, which I'm going to describe their bios here now in excruciating detail. But all I can say is that this work cannot be done by a single individual, certainly not by myself. It really takes a village, in the words of a possible future president, or not. And of course, thank the funders from the federal agencies as well as some private funders as well. And with that, I'll end, and we may have time for questions or get on the highway. Thank you very much.
About adoption. I think one of the challenges is there's a lot of really interesting technology out there, high-tech, whatever. We can talk a lot about the characteristics of the people you're necessarily serving, but one of the things I wonder is, so much of the funding, government money, I guess, from the church communities, are we better served in some cases dealing with a better educated population, if you will, where you can drive adoption of some of these approaches, driving the cost down of these kinds of technologies? Do you have any thoughts on that?
So the question was about what might drive adoption. And I think a very astute point was made that there may be some value. One of the criticisms is, oh, well, that's just rich people who use that, or much more too. But in some ways, you could argue that the smartphone industry originally were higher end users, and now it's kind of seems to be drifting downward in terms of accessibility, socioeconomic status. A group of colleagues in our center who are doing what might be called more traditional coaching, taking the information and showing it to the individual, providing feedback on a regular basis. All right, I think